Hello students, today we are going to discuss a very important topic, not just as a part of undergraduate microbiology curriculum but also as an important clinical diagnosis, that is enteric fever, also known as typhoid fever. So what is enteric fever? It is a potentially fatal multi-system illness, and there are two bacteria implicated. One is Salmonella Typhi, and also we have Salmonella Paratyphi, which are of three species: Paratyphi A, B and C, or which causes paratyphoid fever. So Salmonella typhi, they are typical members of Enterobacteriaceae, Enterobacterialis, previously known as Enterobacteriaceae, and they are facultatively anaerobic, gram-negative bacilli, and they can grow on a wide range of simple media, and it can be distinguished from other members by biochemical characteristics and antigenic structures. So we have a lot of classification, different classifications of Salmonella, but first and the oldest classification is the clinical classification based on typhoidal Salmonella and non-typhoidal Salmonella. So typhoidal Salmonella caused by Salmonella typhi and paratyphi, which is restricted to human host and causes typhoid and paratyphoid fever. Non-typhoidal, it is present, can colonize the intestine of many animals including mammals, reptiles, birds, insects. So after the clinical classification, we have the antigenic classification. So antigenic classification is also known as the Kaufman-White scheme. So it's based on different Somatic O antigen and Flagellar H antigen. So serogroups based on O antigen, there are 67 serogroups, and each serogroup is further differentiated into serotypes based on Flagellar H antigen, and there are more than 2500 serotypes of Salmonella. Third method of classification is molecular classification, recent classification based on DNA hybridization studies. This classifies Salmonella into two species, Salmonella enterica and Salmonella bongori. Now Salmonella enterica is again has 6 subspecies, and you have to remember these are the names of the species: Salmonella enterica, salami, Arizona, Di-Arizona, Houtone and Indica. Now the nomenclature. The nomenclature of Salmonella is very complicated, and it includes the species, the subspecies, the serotype, but we use a simplified format having the genus and the serotype name, and therefore it is known as it is simplified and shortened. For one example is Salmonella typhi. Instead of Salmonella species enterica, subspecies enterica, serotype typhi. So we had classified on basis of the antigenic structure, the Kaufman-White scheme. So what are the antigens? So there are 3 antigen. One is the Somatic O antigen, the Flagellar H antigen, and the surface envelope antigen VI, which is found in some species. Now some characteristics about each of the antigen. Now first is the Somatic O antigen. So if we remember the cell wall of the gram-negative bacteria, we remember that lipopolysaccharide is a very important component. So part of the cell wall, the Somatic O antigen is part of the cell wall lipopolysaccharide, and this is a question. We know that in Vidal test, which is a very important diagnostic modality for the diagnosis of typhoid fever, enteric fever, we use the O antigen for Salmonella typhi. And these next two following points are very important multiple choice questions. The O antigen is less immunogenic, and the antibody to the O antigen, it appears early and disappears early, therefore it indicates recent infection. Now when the O antigen and the O antibody reacts, we form compact, granular and chalky clumps. This is important for the interpretation of the Vidal test. So when the O antigen and O antibody reacts, there is formation of compact, granular and chalky clumps. Now this next point is the optimum temperature of agglutination. It is 55 degrees Celsius. Serogrouping of Salmonella can be done based on the O antigen. Next we have is the Flagellar H antigen. So Flagellar H antigen, it is made up of protein flagellin. So that was O antigen was lipopolysaccharide and Flagellar H antigen is protein flagellin, and in Vidal test, the H antigen of Salmonella Typhi, Paratyphi A, B are used, and it is more immunogenic unlike the somatic antigen, and also in contrast it appears late, disappears late and indicates convalescent stage. Now when the H antigen reacts with the H antibody, there are large, loose and fluffy clumps are formed. So in contrast to the compact granular clumps which was formed in case of the binding of O antigen with O antibody, we have large, loose, fluffy clumps when H antigen reacts with H antibody. In here, the optimum temperature of agglutination is 37 degrees Celsius, and also serogroups are differentiated into serotypes based on H antigen. Next is the VI antigen. What is the characteristic? It is present in only few serotypes and it is a surface polysaccharide envelope or capsular antigen. It is also poorly immunogenic and not used in diagnosis. But there is one significance: if there is complete absence of antibody to the VI antigen in a known case of typhoid fever, it indicates poor prognosis. And this antibody also, if appears early and its persistence denotes a carrier state. So how we are going to detect carrier state is we are coming to it later. And VI antigen, it has got a role in vaccination. Now next we move on to the pathogenesis. What is the infective dose? So this is a question that is asked as a multiple choice. What is the infective dose? It has a very high infective dose, 10 to the power 3 to 10 to the power 6 bacilli. And what is the risk factor? When the stomach acidity is less than 1 year age, or antacid ingestion, or achlorhydria due to previous Helicobacter pylori infection, the chances of infection by typhoidal salmonella increases. Next we come to the clinical manifestation. So we have divided it into symptoms and signs. So this is a question which is asked, which is incubation period of salmonella, which is 10 to 14 days, and it may be as less than 3 days or it may be as high as 21 days. And what is the nature of the fever? It is step ladder pattern or remittent fever. Step ladder pattern, fever rises gradually. So the spike of fever rises gradually and it never reaches the baseline, does not touch normal. The other symptoms we have is headache, chill, cough, sweating, myalgia and arthalgia. Another pathognomonic feature is the presence of rashes, also known as rose spot, which are salmon colored, blanching, maculopapular rash on the trunk and the chest, seen in only 30% of patient. And then we have intestinal manifestations like abdominal pain, nausea, vomiting, constipation or diarrhea. Now what are the signs? The signs are hepatosplenomegaly, may be found on examination, epistaxis, and relative bradycardia and gastrointestinal bleeding and perforation can occur in the 3rd or 4th week of illness. Neurological manifestation, we have is meningitis, cerebellar ataxia, paranoid psychosis, delirium. Rare manifestation is we can have Guillain-Barré syndrome. Also, salmonella may cause osteomyelitis. It is also seen in sickle cell disease. So it may be a rare presentation. Next, we move on to the epidemiology. So humans are the only natural host we discussed for Salmonella typhi and paratyphi, and it is transmitted by ingestion of contaminated water and food. It is more common in the urban surroundings than the rural, and more common in young children and adolescents than the adults. And the ratio of Salmonella typhi is to paratyphi is 4:1. Yet the incidence of paratyphi is rising because of the vaccination against Salmonella typhi. Coming to the carriers, the untreated patients, they become carriers and excrete Salmonella typhi in either the feces or the urine. Now, fecal carriers occur when the typhoid bacilli multiply in the gallbladder and are shed in the feces, and urinary carriers, though the bacilli multiply in kidneys and excreted in urine, though it is rare. Now, duration of shedding, it may be temporary carriers up to 3 months, and chronic carriers, those who shed the Salmonella typhi for even more than a year. Now, chronic carriers are mostly women, infants and old age, and biliary tract abnormalities where Salmonella form biofilms on gallstones. Biofilms on gallstones, they may be chronic carriers, which increases the risk of gallbladder carcinoma. And we know the history of typhoid Mary, or a chronic carrier of a food handler known as, she was the famous Mary Mellon, also known as Typhoid Mary, who were resulting in focal source of a lot of epidemics of typhoid fever. Next, we move on to the laboratory diagnosis. So this particular slide, it solves a lot of problems, because if we pay emphasis, we can detect like which is the judicious use of diagnostic measures. So in the first week of fever, we will decide which specimen to be used for the diagnosis depending upon the duration of the fever. So the type of specimen depends upon the duration of the illness. So in the first week of fever, we always perform blood culture, and if blood culture it is positive in 90% of cases, and if blood culture is negative, we can perform bone marrow culture, or if both are negative, we can do a duodenal aspirate culture. In the second or the third week of illness, so after 7 days, if a patient has prolonged fever, then we will collect serum specimen for serology for Vidal test. But Vidal test is never done in the first week of the illness. And in the third and the fourth week of illness, we perform urine and stool culture. So first is blood culture. Like I said, blood culture is the ideal method of diagnosis in the first week of fever. It becomes positive in 90% of cases. Thereafter, the positivity declines to 75% in second week, 60% in third week, and 25% till fever subsides. Now, blood culture bottle, we have to send a pair of blood culture bottle before the institution of the antibiotic therapy, or if antibiotic has already been delivered, then prior to the second dose of the antibiotic, ideally the blood should be collected, 8 to 10 ml of the blood, and in two containers, either by conventional bottle or automated blood culture, which is Bacti Alert. Now growth occurs in 24 hours and it is a non-fastidious bacteria. So those which are flagged positive blood culture broth, it is inoculated into blood agar and McConkey agar. Coming to the culture characteristics. Culture characteristics we have in blood agar. We have non-hemolytic moist colony, and in McConkey agar we remember the traditional classification based on lactose fermentation of Enterobacterialis, and Enterobacterialis there may be lactose fermented, late lactose fermented and non-lactose fermented. Examples of non-lactose fermented is Salmonella and also Shigella. And Proteus, there are other examples, but here we are paying emphasis that the in McConkey agar the colonies are pale and non-lactose fermenting. Now enrichment broth. So enrichment broth is a liquid media and it is used for enhancing the growth of the Salmonella. So there are selenite F broth and tetrathianate broth and gram-negative broth. These are again multiple choice questions. So we have to know the enrichment broth for Salmonella is selenite F and tetrathianate broth. Also we have to remember the selective media. Selective media we have three. One is the deoxycholate citrate agar, DCA, and xylose lysine deoxycholate agar, also known as XLD agar, where we see red colonies with black center, and Wilson Blair brilliant green bismuth sulfate media. So deoxycholate citrate agar, where we find non-lactose fermenting pale colonies with black center, xylose lysine deoxycholate agar, red colonies with black center, and Wilson Blair brilliant green bismuth sulfate. So this is the image, three images. One is the non-lactose fermenting colonies is seen in McConkey agar, and in XLD agar we see red colonies with black center, and this is again the pale colonies seen in DCA agar. So other specimens we can do bone marrow culture in the first week when blood culture is negative or patient is already on antibiotics. Next, duodenal aspirate can be used if both blood and bone marrow culture are negative, and combination culture is ideally most effective. Coming to the culture smear and motility testing. So since it is an Enterobacterialis, it will be a gram-negative bacilli, non-sporing and non-capsulated, and the motility, Salmonella is motile with two exceptions. Salmonella is motile with peritrichous flagella, but non-motile Salmonella we have is Salmonella gallinarum and Salmonella pullorum. So this is the exception. And identification based on the battery of biochemical test, we have two biochemicals based on the other classification of Enterobacteriaceae, which is catalase positive and oxidase negative, and this mnemonic we have for ICUT. All are negative. Indole citrate urease and triple sugar iron agar test, all are negative. In triple sugar iron agar we find alkali over acid, and there is a slight H2S production, hydrogen sulfide production at the junction between the slant and the butt of the triple sugar iron agar. Slide agglutination test can be performed, and it is first done by polyvalent antisera O and then followed by type specific O antisera. For example, Salmonella Typhi agglutinate with O9 antisera and Paratyphi A agglutinate with O2, Paratyphi B with O4 antisera. So this can be remembered. Although it is not, it is purely for identification on serotyping, not for clinical diagnosis. And next, second week. Now we come to the second week or third week of illness. So here we are going to perform the Vidal test, which we are going to collect serum for the detection of antibodies. So in Vidal test we are detecting antibodies in the patient's serum against known antigens of Salmonella Typhi and Salmonella Paratyphi. So the four antigens that we are using is O antigen of Salmonella Typhi, TO, H antigen of Salmonella Typhi, H antigen of Salmonella Paratyphi, AH, and H antigen of Salmonella Typhi, Paratyphi, BH. So why we are not using the O antigen, paratyphoid O antigen? They cross react with typhoid O antigen due to the so we do not use the paratyphoid O antigen because they cross react with the typhoid O antigen due to sharing of a factor 12. Now the procedure and the results. So we serially dilute the serum of the patient and mix it with the 4 different Salmonella antigen, and the test tubes are incubated in water bath at 37 degrees Celsius for 24 hours, and the results are seen at the base of the test tube. It is read using a concave mirror, and if antibodies are present, agglutination reaction will occur leading to mat formation, and if there is no agglutination due to absence of antibodies, there will be a button formation. And we go back to our previous discussion, we know that when O antigen reacts with the O antibody, there is formation of compact granular chalky clumps, and when the H antigen reacts with the H antibody, it forms fluffy cotton woolly clumps. So here is the diagrammatic representation. This is the slide agglutination, which is again performed in some cases, and here we are performing the tube agglutination with serially dilution of serum and addition of the antigen. So it may give rise to either if there is agglutination, there will be presence of clumps, mat colonies, mat formation, mat formation at the end of the tube, or it may be the clumps for O antibody it will be granular chalky, and for H antibody it will be cotton woolly clumps. Now how do we interpret the Vidal test? Since Vidal test in our endemic country, we have to consider a H antibody titer of more than 1:200 to be considered significant, and O antibody titer of more than 1:100 to consider significant. In Salmonella Typhi infection, antibodies TO and TH are raised, and Paratyphi A also we have antibodies to TO and AH antigen raised. Paratyphi B, antibodies to TO and BH antigen are raised. Now Vidal test may be either false negative or false positive in some situations. False negative when it is very early stage of illness, fever duration is very less, prior antimicrobial therapy, or when there is prozone phenomena, lattice formation due to antibody excess. And false positive results, also known as anamnestic response. So this is seen when there is transient rise in titer in unrelated infections like malaria, dengue, and those who have had a previous history of enteric fever, and the rise in titer is very transient, it falls after 1 week. In true infection, titer rises by 4-fold after 1 week. So this is anamnestic response. Next we move to detection of carriers. So carriers, we have seen that the bacilli multiply in the bile or the urine, and the detection of VI antibodies was used for the detection of carriers. So it is detected, the antibodies are detected by an antigen known as the VI antigen of Bhatnagar strain, and a titer of even 1:10 is considered significant. We move on to the treatment of the cases. Treatment of the cases we have is third generation cephalosporin, ceftriaxone, which is the drug of choice, and azithromycin can also be used as an alternative drug for empirical therapy. And in the treatment of carriers, we use ampicillin or amoxicillin along with probenecid for 6 weeks. Previously, we used to use chloramphenicol, cotrimoxazole and amoxicillin, but these had been curtailed due to emerging drug resistance. So with this, we have discussed majority of the topic of enteric fever. I hope I could aid you in discussing the topic in details, as well as in solving some very frequently asked questions. Thank you.